Welcome to this comprehensive clinical overview of cholecystitis, which literally means inflammation of the gallbladder. We will cover its definition, underlying disease mechanisms, and appropriate management strategies. The pathophysiological chain reaction begins with the obstruction of the cystic duct, typically by a gallstone. This causes bile to accumulate, increasing pressure and leading to inflammation. The inflammation can then reduce blood flow, causing ischemia and cellular necrosis. We can distinguish three variants of cholecystitis. Acute calculus, driven by gallstones, is the most common. Acalculous cholecystitis is critical and often associated with trauma or sepsis. Finally, chronic and rare forms are driven by repeated acute attacks leading to fibrosis. Key risk factors for cholecystitis include demographic factors like being female, over 40, or of American Indian descent. Physiological risks include pregnancy, obesity, rapid weight loss, and certain medications like oral contraceptives. Acalculous forms are linked to critical illness or major trauma. Symptoms typically involve severe, constant pain in the right upper quadrant, often radiating to the right shoulder. This is known as Boas's sign. Systemic indicators include nausea, vomiting, and occasional fever. It is differentiated from biliary colic by its severity and duration. The hands-on examination includes Murphy's sign, where deep inspiration while applying pressure causes a sudden arrest of breath due to pain. Palpation may reveal tenderness or a palpable gallbladder mass. The jaundice check helps identify complications like cholecystitis. Biochemical evidence typically shows elevated inflammatory markers, specifically white blood cell count and C-reactive protein. Liver and biliary function tests may show a mild elevation of bilirubin. Significantly elevated bilirubin warrants investigation for common bile duct stones. RUQ ultrasound is the gold standard for diagnosis. It looks for gallstones, wall thickening, paracholecystic fluid, and sonographic Murphy's sign. A HIDA scan is a secondary tool used when ultrasound results are equivocal. A CT scan is tertiary, used for suspected complications. If untreated, cholecystitis can critically escalate. Phase 1 is gangrene, where tissue dies due to blocked blood flow. Phase 2 is perforation or rupture, leading to severe complications and a high mortality rate. Phase 3 is empyema, a collection of pus within the gallbladder. Structural failures include fistula formation, where inflammation creates abnormal connections to the duodenum. This can lead to gallstone ileus, an intestinal obstruction. Associated inflammations include gallstone pancreatitis and cholangitis, an inflammation of the common bile duct. The surgical standard is laparoscopic cholecystectomy, a minimally invasive procedure with benefits like less pain and a shorter hospital stay. Timing is critical, with an early procedure within 7 days of symptom onset being recommended. Delayed surgery may be necessary if inflammation is too severe. Preoperative support includes fluid resuscitation, pain control with opioids, and targeted antibiotics. For high-risk patients, percutaneous cholecystostomy is an alternative procedure involving drainage to resolve acute inflammation, acting as a bridge to surgery once the patient stabilizes. In summary, cholecystitis is primarily caused by gallstones, and diagnosis relies on RUQ ultrasound and Murphy's sign. The treatment of choice is early laparoscopic cholecystectomy. Monitoring for signs of gangrene or perforation is vital due to the high mortality risk associated with these complications.